Good morning, everyone. It's my pleasure to welcome you to our webinar, An ICD-10 Code for Sarcopenia, Implications for Diagnosis and Clinical Practice. My name is Cynthia Benz, and I serve as Vice President of Public Policy at the Alliance for Aging Research, and I also serve as Executive Director of the Aging in Motion, or AIM Coalition, and I'll be moderating today's program. Before we begin, I'd first like to provide some background on sarcopenia and the AIM Coalition. Sarcopenia is age-related loss of skeletal muscle. Starting in middle age, we all begin experiencing muscle loss, no matter how much time we spend exercising. The problem is that for some people, this loss of muscle is faster and more severe. Their muscle loss impacts their strength. This group of people gets into trouble later in life when they don't have enough strength to do the things they need to do to live independently. These older adults find it increasingly difficult to stand up, walk, climb the stairs, cook, buy groceries, and even use the bathroom without assistance. They also tend to have more complications recovering from injuries commonly experienced by the elderly, like hip fracture. An inability to carry out activities of daily living or to fully recover from injuries are major causes for many older adults ending up in an assisted living facility or nursing home. This institutionalization is at great human and financial cost to individuals, their family, and to society. The AIM Coalition is made up of 36 nonprofit, patient, and research advocacy organizations working together to increase recognition of sarcopenia and age-related functional decline. AIM was founded in 2011, and our core goal is to promote clear clinical development and regulatory pathways for effective treatments that can improve the lives of people with sarcopenia. We do this by convening some of the greatest minds who are conducting research in this area, and our current scientific advisory board is listed on the slide. It's led by Dr. Jack Gorelnik. AIM engages with industry to strategically undertake activities that will produce results that are of use in the diagnosis and treatment of sarcopenia. We also work directly with the regulatory bodies to advance our activities because we want to be sure what we do meets their needs as well. We've had positive and ongoing interactions with the FDA on this condition. Among other things, FDA continues to work with AIM on the qualification of the short physical performance battery and usual gait speed for use as performance outcome measures in clinical trials. They'll also convene a patient-focused drug development meeting on sarcopenia in April of 2017 to increase their understanding of sarcopenic patients' experiences and expectations for potential treatments. We're incredibly excited about the doors both of these efforts will open for sarcopenia product development. In addition to our work with FDA, AIM submitted a proposal to the Centers for Disease Control and Prevention in July of 2014 to establish an ICD-10 code for sarcopenia. After some revision, the CDC accepted AIM's proposal and announced that the ICD-10 CM code would be available for the medical community to use effective on October 1st of 2016. And you're going to hear a bit more in our first presentation today. The webinar today is going to provide expert insights into the process for requesting the addition of this code, the significance of the sarcopenia code in the clinical setting, and the value of an ICD-10 data for continued research. And we have three stellar speakers for you this morning who's going to provide their thoughts on this very subject. Questions will be reserved for the Q&A period at the end of the program, but as you think of questions, you can feel free to use the WebEx chat function or email me at cbenz@agingresearch.org, and I can add them to the question queue. I'd like to recognize AIM sponsors, Abbott Nutrition, Astellas, Cytokinetics, GE Healthcare, Hologic, Novartis, and Nutricia. Without your support, programs like the one today would not be possible, so thank you so much for your commitment. In addition to our sponsors, I'd like to thank my colleagues Sarah DeGiovanni, Noel Lloyd, and Ryan Carney for their help with the webinar. We're fortunate to have Linda Holtzman as our first speaker. Linda is the founder of Clarity Coding. She spent over 20 years with experience as a medical coder in both the hospital and physician settings. She spent much of her early career in the payer community, where she conducted all functions directly related to coding, developing edits, maintaining fee schedules, and performing audits. This experience has given Linda a broad view of coding and its implications. Linda currently serves as an adjunct professor in the Department of Health Information Management at Temple University, where she teaches coding to the next group of coding professionals. Linda will provide us with an overview of the ICD-10 and the process that she guided AIM through to have an ICD-10 diagnosis code established for sarcopenia. So Linda, please take it away.
Hello, everyone. For the next 20 minutes or so, I'll be taking you through the process of how a new ICD-10-CM diagnosis code for sarcopenia was created. And I'm a good person to do this because, as you heard from Cynthia, I'm a professional medical record coder, and I'm the one who guided the Alliance through this process as well. First, let's make sure we're all on the same page. What is ICD-10-CM anyway? Next slide. ICD-10-CM is the coding system we use to capture diagnoses. ICD-10-CM is actually part of a worldwide coding system that's used by all countries belonging to the World Health Organization through the United Nations. So Japan and Nigeria and Argentina and France and Turkey and Guatemala and countries all over the world use ICD-10-CM, which, by the way, is why the I in ICD stands for International Classification of Diseases. ICD-10-CM is the version adapted for use in the United States. And it's not optional. Use of ICD-10-CM is actually mandated by HIPAA. We used to use ICD-9-CM, also mandated by HIPAA, but after 35 years, ICD-9-CM was replaced by ICD-10-CM in October 2015. You've probably heard of CPT, which is the coding system for physician services and hospital outpatient services. There's also the coding system HCPCS, which is used for things like drugs and supplies. But there's only one diagnosis coding system in the U.S., and it's ICD-10-CM. Physicians and hospitals and ambulatory surgery centers and medical laboratories, all providers, report diagnoses using ICD-10-CM. Now, why do these healthcare providers need to report diagnoses in the first place? It's because diagnosis codes are used for essential analysis of healthcare data on both the local and national level. Diagnosis codes are also essential to payers who use them to adjudicate claims for coverage and to determine the reimbursement to the provider. When ICD-10-CM first went into effect in October 2015, there was no specific code for sarcopenia. Happily, there is now, and here it is. Next slide. It's code M62.84, and it's defined simply as sarcopenia. All the other stuff on this slide, well, that's in the ICD-10 codebook as well. It mostly involves proper use of the sarcopenia code, particularly in relation to other similar codes. So code assignment is more technical than it may seem at first, and you need to understand what all the different components connote and how they all hang together. But before we talk about all that, let's start by going through how we got to this point in the first place. Next slide. ICD-10 is managed by the ICD-10 Coordination and Maintenance Committee. Of course it is. This is informally known as the C&M Committee. And as you've probably surmised, prior to October 2015, it was the ICD-9 Coordination and Maintenance Committee. Now, this is a federal intergovernmental committee, and people often assume that the ICD-10 Coordination and Maintenance Committee must be run by CMS. It is, but only for the procedure code portion. The diagnosis code portion of ICD-10-CM is actually run by the Centers for Disease Control. So that's who we had to go to get the new created. The C&M Committee, co-chaired by the Centers for Disease Control, meets twice a year. I've been going to the C&M meeting since 1985, and my experience has been that it's actually a pretty reasonable process and significantly less political than you might think. Meetings are open to the public. Everything is available online, including videos of the proceedings. They encourage comments from the public, and there are many, many examples of when the committee's decisions have been swayed by public input. You can get a new code in as little as 6 months, though 12 to 18 months is more common. Now, here's a typical timeline for getting a new code. A request must be submitted 2 months before the committee meeting. The committee always meets in September and March. So you would need to submit in July 2015 to make the fall 2015 meeting in September, when the request is presented and discussed. After the meeting, public comments are due within 2 months. The requester can also use this time to suggest revisions to the original proposal based on feedback from the meeting. Time keeps moving, and in January 2016, it's already the deadline to submit requests for the spring 2016 meeting in March. Now, requesters don't hear back directly from the committee on their decision. There's no individual notification. Requesters find out whether or not their requested code was approved. They find out the same way everybody else does, in the proposed Medicare Hospital Inpatient Prospective Payment System rule, which always comes out in April. The wording is a little bit confusing here, in that the proposed rule proposes changes to hospital inpatient DRGs, but the new codes it reveals are final. The rule only contains a listing of the new codes. And as you saw earlier, there's a lot more to a new code than just the code number and its description. So for the whole picture, we need the official addenda, which are released every year in June. And the official addenda show the new codes in context, including all the new notes and other conforming changes within ICD-10 CM. Then the final Medicare Hospital Inpatient Prospective Payment System rule is released on August 1st. That has the final DRG changes, and then the new DRGs and the new codes go into effect together on October 1st, the start of the federal fiscal year. This timeline represents a normal cycle, but as we'll see, the request for sarcopenia got caught up in unusual circumstances with the transition from ICD-9 to ICD-10. Also, not all code requests are granted, not at all. The C&M committee has very specific criteria. Next slide. There are 5 basic elements the C&M committee looks for, and they want to see all 5 before approving a new code. First, the diagnosis has to be real. In other words, it can't represent medicalization of a normal condition. Second, the condition has to be understood and applied consistently by physicians. In other words, there needs to be a consensus definition within the medical literature. Third, the diagnosis has to be distinct from other related diagnoses. It can't be an integral component of another diagnosis, and there has to be a way to tell the difference between the two. Fourth, the diagnosis has to be common enough. In other words, specific codes aren't usually created for a very rare diagnosis. And finally, it has to be worthwhile to have a specific code. Do people want to collect data on this condition? If they do, why? What are they going to do with that data? What are they going to use the data for? The committee wants some assurance that it's for outcomes analysis rather than, for example, marketing purposes. So you can see what we were up against in requesting a new code for sarcopenia. Next slide. A new code request has 2 parts. There's the clinical background and then the proposed structure of the new code. In the clinical background portion of our request, we tried to speak to all of the criteria by outlining the evolution of sarcopenia as a distinct diagnosis. We refer to the consensus definition arising from the Foundation for the National Institutes of Health Sarcopenia Project and the European Working Group on Sarcopenia in Older Persons, as well as the standardized tests and objective findings used to determine if a patient has sarcopenia. We stress the impact of sarcopenia on functionality and how early identification allows for preventive measures and interventions. Then in the proposed structure for the new code, we proposed instructional notes that would help coders differentiate sarcopenia from related conditions like muscle weakness, which already have their own codes. This would help ensure that coders assign the new code we requested properly and consistently. We submitted our request for the fall 2014 meeting of the Coordination and Maintenance Committee. That was in September 2014. Unfortunately, things didn't go quite as smoothly at the meeting as we had hoped. Next slide. It actually started off pretty well, with comments from various professional coders. One comment came from the coding representative of the American Hospital Association, who is also the editor of the premier professional coding journal in the United States and has a great deal of influence with the C&M committee. She made a comment on the notes that we wanted to add, and this was actually a good sign in that she wasn't objecting to the proposal itself. She just wanted to clarify some technical points. But then came a comment from the representative of the American Academy of Neurology, and that's where we ran into some speed bumps. The AAN representative raised several concerns. First, she objected to the fact that AAN had not been involved in the coding request. She also raised clinical concerns, such as the potential to conflate sarcopenia with primary muscle disorders and myopathies. Now, although we had checked in with other clinical groups before the C&M meeting, it honestly hadn't occurred to us to run the proposal past the American Academy of Neurology. I might note that if the CDC itself isn't sure, they will reach out directly to a particular medical specialty society before the C&M meeting, but they hadn't contacted AAN either. So it was just an all-around oversight and one we had to correct. Well, we could have done without all this fuss, but it doesn't doom a coding proposal. In fact, that kind of back and forth happens with a lot of coding proposals. That's the point of holding a public meeting, and we appreciated AAN raising these points. We still have a comment period of 2 months from September to November to revise the code proposal and try to address AAN's concerns. And we did. Next slide. We spent 6 weeks going back and forth with AAN. There were 2 key turning points. The first was that Dr. Studensky of the National Institutes on Aging, she spoke directly with the AAN representative and provided additional literature that allayed their clinical concerns. Also, in a wonderful stroke of luck, the AAN representative polled the AAN coding committee and learned that one of her colleagues had actually studied sarcopenia during a fellowship and was in support of creating a new code. The second key turning point was when AAN made some suggestions for the code structure. That's small, but it showed that AAN no longer opposed a code for sarcopenia, but had transferred their concerns to the structure that code would take. We could work with that. We revised the proposed code structure to incorporate suggestions from AAN. And then, with AAN's concurrence, a revised version of the proposal was sent to the CDC prior to the close of the comment period. We also reached out to important coding groups to let them know that we had resolved things with AAN. And this was to prevent those coding groups from voicing formal opposition based on AAN's opposition at the meeting. Once they knew that AAN was on board, they could feel more confident supporting our proposal as well. After all that flurry of excitement, the next thing that happened was not much. Next slide. As we said, the new code request was presented at the September 2014 C&M meeting, and then the revised version went to CDC in November 2014. We thought we might need to come back to the spring 2015 C&M meeting with a revised proposal, but CDC advised us there was no need for that. So then we waited. Remember, CDC does not inform requesters individually. You find out when the new codes are published. On October 1st, 2015, just a year after our request at the September 2014 C&M meeting, ICD-10-CM went into effect. But to smooth the transition, no new codes were permitted that year, so we still didn't know. Then in April 2016, a year and a half after we made our request, CDC posted a first look at all the new ICD-10-CM codes, and sarcopenia made the cut. But that was informal. We had to wait until the Medicare Hospital Inpatient Prospective Payment System rule and the official addenda were released. And there was sarcopenia again. The new code for sarcopenia went into effect October 1st, 2016. Now, what was that code again? Next slide. We saw this before on slide 3, and here's what it really means. The new code is M62.84. Codes that start with the letter M are in the musculoskeletal chapter of ICD-10-CM, so sarcopenia is classified as a musculoskeletal disorder. Underneath the code description is the phrase age-related sarcopenia. That's an inclusion term, just a note to the coder to say that age-related sarcopenia is assigned to M62.84 also. Then there's a code first note underneath that. This note was added to address AAN's concerns. It means that if sarcopenia is due to, for example, a myoneural junction disorder or certain types of myopathies, then assign the codes for those disorders and sequence those codes first. Do code sarcopenia also, just sequence the sarcopenia code second. Then there are notes elsewhere within ICD-10-CM which relate to sarcopenia. Under code M62 for muscle wasting and atrophy, and under code M62.81 for muscle weakness, there are excludes one notes. They alert the coder that if the muscle wasting, atrophy, or weakness is associated with sarcopenia, don't use those codes. Use the sarcopenia codes instead. Likewise, don't assign code R53.1 for weakness or R55 for age-related debility. If those symptoms are associated with sarcopenia, use the sarcopenia code. All of these notes and instructions are intended to help ensure that sarcopenia can be accurately assigned and identified within the encoded data. What else does having an ICD-10-CM code for sarcopenia mean? Next slide. Here's what it means. It means that the Centers for Disease Control now recognize sarcopenia as a separately reportable condition. That phrase, separately reportable condition, is carefully worded because that's what coding is about. A new code may well have the effect of recognizing sarcopenia as a new diagnosis, but coding is about reporting conditions. The main thing is that a new code removes barriers to physicians diagnosing this condition. It removes those barriers that they may have faced in reporting it. It standardizes recognition of sarcopenia among the healthcare community, and it gives access to more comprehensive data to researchers. The hope is also that sarcopenia will follow the course that obesity took. Once a code was created for obesity as a distinctly reportable condition, that resulted in better recognition and more frequent diagnosis, as well as more frequent intervention by physicians, and eventually better coverage for those interventions. It also attracted resources for research, and not only in the United States. Although the U.S. just adopted ICD-10, ICD-11 is now being drafted by the World Health Organization. Creation of the ICD-10-CM code for sarcopenia in the U.S. may well encourage creation of a new code for sarcopenia in the international version of ICD-11. Well, I hope this information has been useful to you. Let me now turn things back over to Cynthia Benz, who will introduce the next speaker.
Great. Thank you so much, Linda, for that really informative presentation. Next, I have the pleasure of introducing Dr. Doug Keel. Dr. Keel is the director of the Musculoskeletal Research Center. He's a senior scientist in the Institute of Aging Research and a professor of medicine at Harvard Medical School. Dr. Keel's research focuses on the epidemiology of osteoporosis and related fractures, including lifestyle factors, biomarkers, and genetic factors. He's interested in sarcopenia and its consequences, including falls and disability. Dr. Keel leads the Framingham Osteoporosis Study, and he's conducted multiple clinical trials targeting the musculoskeletal system. He serves in leadership roles for many organizations, including the National Institutes of Health, the American Society for Bone and Mineral Research, the National Osteoporosis Foundation, and the Joint Commission. Dr. Keel is joining the program to share his thoughts on the value of having the ICD-10 code for sarcopenia and what healthcare providers can potentially do to utilize the code right now.
Thank you very much, Cynthia. Yep.
The slides are all yours.
Okay. Thanks, everyone, for joining the webinar this morning on the East Coast. I'd like to first, advancing the slides could be an issue here. Cynthia, I'm not able to advance the slides. So,
Okay, Jack, I can advance them for you. Oh.
Whoops. I don't see my slide set up there. There you go. Thank you.
You're welcome.
So I always like to have reveal any disclosures to the audience. So I have grant funding as part of the Foundation for NIH Sarcopenia Project, and have received grants and act as a scientific advisor for Merck, Sharp and Dome and policy analysis, and receive royalties for some publications. Today I will be helping to define sarcopenia. You heard from the first speaker that from a coding standpoint, it's pretty specific as how you code sarcopenia, but I will tell you that we're still making advances in defining it, and I will review some of the work we've done over the years. And then once we have a definition, how do you assess it in the clinic when a patient presents with potentially this diagnosis? And then once you diagnose this, how will you approach it in treatment? So you've heard about the code, and I won't go into this in great detail, but it is now a reportable condition in our coding, and we have now the task of trying to assess this clinically and treating it. Some of you may have seen this slide. The nomenclature for sarcopenia, while the coding was so elegantly crystallized by Linda Holtzman in the first talk, and all the years of work that went into precision in the definition, if you look at the term sarcopenia, which is shown here in the lower left, there's another word that you might hear called dynapenia, which is weakness of the muscle. Sarcopenia is more equated technically with the mass of the muscle. And in order for the muscle to contract and perform a function, to perform locomotion and other activities that humans and animals perform, this is a complex interaction of the neurologic system, which is why the neurologists got involved with all of this. But there's also hormones, there's immune function, there's dietary intake, there are integrations of the nervous system with the muscular system to create this finely tuned ability to locomote and perform functions. And sarcopenia is only one contribution to the ability of a human being to move around and to perform functions. So in order to get a better handle of sarcopenia, several years ago, the Foundation for the National Institutes of Health, under the organization called the Biomarkers Consortium, developed a project to actually derive a working definition of sarcopenia that could be used clinically that was not based on expert opinion, but rather on data. And so the ultimate goal of the Sarcopenia project was to create an evidence-based definition by generating some clear and valid criteria and outcome measures that would be acceptable to practicing clinicians, the FDA, insurers, and the Centers for Medicare and Medicaid Services. It would offer opportunities to develop and test potential interventions if we had a definition on low muscle mass and strength, and this could lead to improving the health of older adults. Also, by creating a definition, this would provide clinical recognition and practice guidelines for screening, diagnosis, and management. up until this point, you might have been aware of the fact that there were expert consensus opinions emerging from Europe and other places. And in 2010, the European group under Dr. Cruz-Gentoft's leadership defined 3 stages of sarcopenia: pre-sarcopenia, and sarcopenia, and severe sarcopenia. And they based these definitions on the muscle mass measured by imaging techniques such as dual energy X-ray absorptiometry or bioimpedance analysis. They also considered strength and performance, such as gait speed or the short physical performance battery. This definition was based on expert opinion, and what was used to define thresholds for the definition were simply taking a distribution of values for different measurements and coming up with a threshold based on an extreme borderline, or moving to the extreme of the distribution, coming up with a threshold. A group of additional researchers considered sarcopenia in 2011 in a paper published in the Journal of the American Medical Directors Association. Again, this was a sarcopenia diagnosis observing a decline in physical function, strength, or overall health was the flag to consider this diagnosis. And it couldn't arise independently. Persons with this diagnosis couldn't stand up from a chair, couldn't walk fast enough, had some mobility problems, maybe some chronic conditions and hospitalizations. But the diagnosis of this group was advocated by using a gait speed and, again, DEXA. So how fast could you walk and how much muscle did you have or lean mass did you have using DEXA? They didn't include strength measured as the European group had, but again, it was primarily an expert opinion and consensus type of definition. That led to the approach that the FNIH project took, which was to use cross-sectional and prospective data from several aging studies to evaluate criteria for sarcopenia by pooling the evidence or the data from these studies. The project also presented its findings to a broad professional audience, which took place in 2012, and also published the findings to disseminate this activity. And let me give you a little bit of background about the data. There are many ways to analyze data that include information on older individuals, their function, their strength, their muscle mass, their lean mass, whatever. The approach that was taken in this project was to use a technique called classification and regression trees. This was the primary analysis for analyzing the data from the studies, using this type of approach to derive the cut points for strength and lean mass. This technique partitions individuals in the studies into mutually exclusive groups defined by predictor cut points, so that people who are below or above a cut point are the most similar as can be derived in a statistical analysis. It doesn't have any assumptions of the distributions of the variables, and it has several advantages, such as being able to optimize the validity by identifying predictors and cut points that have the strongest relationships with a given outcome. You don't have to specify the number of cut points that you wish to have, and this technique can identify interactions between the variables. It's widely used in biomarker research, and it had been used previously to study the association between strength and walking speed, and that's why we used it. The FNIH Sarcopenia project had several studies involved that are shown here, just so you get a flavor for this. The study MROS, Mr. Oss, was primarily begun as an osteoporosis study, but became more broadly musculoskeletal. They had mobility measures such as walking speed, grip strength, leg strength, DEXA. Another study from California had called the Rancho Bernardo study, had similar measurements. And you get the theme here as we go down the list that the studies had in common some measure of mobility, measures of strength, and measures of muscle mass or lean mass. Puerto Rican study was also included to expand the ethnic diversity, as well as having data on all of the three elements. Also, we were able to include 6 clinical trials that tested various interventions to improve sarcopenia. And these 6 clinical trials contributed data on the same endpoints that we were interested in. There are also the Chianti study that you might have heard about from Italy, the Framingham study from Massachusetts, the Health ABC study, which was an NIA study begun by Tamara Harris and her colleagues, and a study of older individuals from Iceland called the AGES study. Again, what is shared across these studies is the availability of data on mobility, strength, and lean mass. After a year or more of combining all of these different studies of older individuals using the CART method, the model that we used was to try to predict who would be a slow walker, 0.8 meters per second or less. And it turned out that using the best CART models, a grip strength threshold of 26 kilograms for men and 16 kilograms for women was the best discriminator of slow and fast walkers, which we deemed to be a functionally important outcome. And it turned out that the cut point for grip strength, when standardized to an individual's body mass index, was slightly better discriminator than pure grip strength. And so we developed a grip strength to BMI ratio which optimized the discrimination of slow and faster walkers. Separately, appendicular lean mass measured by DEXA also yielded a cut point that differed between men and women. And we looked at a secondary criteria for low lean mass, again, taking into account BMI, with the thought that a given amount of lean mass would not create enough strength to move a body around if that body was heavier. And so there might be a need to account for the size of the body that was being moved to produce the walking speed. And so we developed a criterion that included the BMI, again, with different cut points in men and women. So how do these actually perform when we looked in the data longitudinally? The low grip strength, or the low grip strength divided by BMI, or the low appendicular lean mass divided by BMI, did predict the development of new slow walking speed in people who were walking pretty well to begin with. We were able to do this because we had longitudinal measures of walking speed. So if you had low grip strength or low grip strength over BMI or low appendicular lean mass, each of these was associated with a greater likelihood of developing slow walking. So let's put this together and think of it in a clinical context. And that's what we tried to do in this project. Who would you be screening with whatever criteria you'd choose? And in the clinic, people are not going to come to the doctor or to the healthcare provider and say, "Doc, I have sarcopenia," and tell you what the ICD-10 code is. They're likely going to present to a healthcare provider with poor physical function. So the question is, what is the best measure of physical function that we can use to tell that our patients have poor physical function? We would advocate that if a group of patients does present with some measurement of poor physical function, one should determine whether there is weakness experienced by the patient, some objective measure. What can we do to measure weakness in people with poor physical function? If we had a measure and someone was weak, then we would need to determine, is the weakness due to low muscle mass? If it is, then we have a diagnosis of sarcopenia. But some people could be poorly functioning. They could be saying they're weak, or we could measure that they were weak. But when you measure the muscle mass, it doesn't look like it's below a normal range. And so then we would look for non-muscle mass causes of low muscle mass. And so this is sort of the clinical paradigm. And in order to operationalize this, we need some measurement in the clinic that would enable us to use this kind of thinking in our diagnosis. So how do we assess poor physical function? We can ask people, how are you performing in terms of your physical function? We can ask people if there's been a decline in some of their functional activities, such as climbing stairs. One of the things that we often observe that our patients can no longer open jars because they are weak, and this is a question that might be considered. Or they might not be able to lift objects. They can't go shopping because the bags are too heavy and they are weak. They can't get out of a chair. And we can also turn to objective measures that don't rely on an individual's opinion, but is an objective measurement of function, such as gait speed. So just to remind you, we in our FNIH project, we used weakness, we used muscle mass. So the weakness was measured with hand grip. The muscle mass was measuring DEXA, or you can divide the hand grip by BMI, or the lean mass can be with or without BMI consideration. And we had these cut points. So how can we measure the low strength? And the reason to do this, you've heard from Linda, is that we have to be able to place sarcopenia into other conditions, such as she described in this very nicely articulated classification scheme. But in the clinic, we see patients who have some of these conditions. Some of them are primary muscle conditions. At the end of the day, they still have sarcopenia. Most of what I will be finishing my closing remarks are the primary sarcopenia, age-related sarcopenia, 62.8, 62.84, that comes from an age-related decline in muscle strength and mass. And in order to attend to the patient who says they are having problems with their mobility and they might be weak, we can measure the components here. We can do a whole body DEXA scan. These are available around the United States, and by doing a whole body DEXA, you can generate images like these here, where an individual who says they're having problems with mobility, if you measure their muscle mass, which you can focus your attention on the leg, and you can see the bone, the femur bone, the tibia, and the fibula, but surrounding this is the slightly less white-colored gray material, which is the lean mass in the lower extremities. And if you look at a person here on the left who might be considered frail or weak or mobility impaired, and then you come over to the right, you can see that there could be individuals who are obese and their muscle mass looks pretty good compared to the image on the left. But you can actually see individuals who are obese and hardly in the legs, they hardly have any lean mass. They sort of look like the person on the left who has neither obesity nor muscles to speak of in the leg. So you can see that by measuring DEXA, which is a clinically available test, you can quantify the amount of lean mass, and that can be used in the thresholding of individuals to see if they have sarcopenia. You can also, in the clinic, you can measure strength. There aren't too many clinics that have devices like the woman shown on the left, who are sitting on a simple chair with a pulley device that enables them to lift their leg against a resistance. You can put weights on here, and you ask the individual to straighten their leg against resistance, and you keep putting a weight on until you reach the maximum ability to extend the leg against a fixed weight of resistance. This is a little bit more in the research realm. You don't see too many of these except in the physical therapist's office or in the rehab setting. But in the office practice, a simple measure of grip strength, which we used in our FNIH project, would enable someone to measure grip strength. And you can also, in the office, measure gait speed as a objective measure of slowing and mobility disturbance. Now, once we have the diagnosis, either because someone presents, we measure their gait speed, and gait speed, by the way, is a very strong predictor of mortality, as shown in this study by Stephanie Studensky. Shown here is the survival according to gait speed. So at any age, the gait speed, as it drops from higher levels to lower levels, predicts mortality, which is why an objective measure of gait speed can be an important way to quantify people who say they are having problems with their mobility. Once you have the diagnosis, you might still say, what do we do now? We have someone who's a little weak, their muscle mass is a little low, below the thresholds that people have ascertained. What do we do now? Well, we have several approaches, and I would point your attention to this review in 2014 suggesting that there's moderate quality evidence that exercise interventions can improve strength and performance. Results of nutrition interventions were a bit equivocal because there weren't enough studies and they had different study designs. But in general, supplementing amino acids specifically showed some effects in improving muscle mass, and the use of protein supplements had some promising effects, but not consistent on muscle mass and function. So there is some suggestion that exercise and nutrition might be useful. And this review in 2016 by John Morley talks about some of the currently available drugs or drugs that are in development to address the sarcopenia treatment challenge. And you can see here that these drugs range from hormones such as testosterone, androgen receptor modulators, growth hormone, ghrelin agonists, myostatin antibodies, activin receptor 2B antagonists, even blood pressure pills, ACE inhibitors, a adrenergic receptor antagonist, and a troponin activator are therapies that are either available or in development. None of these are specifically approved for sarcopenia, but they are available, and some people are studying their safety and efficacy. You can see that in studies to date, testosterone, SARMs, and ghrelin agonists, myostatin antibodies, they increase muscle mass. In some situations, it's been shown to increase strength. They increase walking distance in the case of ACE inhibitors. But there are side effects that have to be taken into account, as shown in this table reviewed by Morley et al. So let me finish by saying I believe that in the very near future, if not right now, patients presenting to physicians and healthcare providers with poor physical function, either by self-report or by measurements such as gait speed, should be screened with a strength measurement, perhaps a lean mass measurement, and if sarcopenia is the diagnosis using those evidence-based thresholds I spoke of, there is some attention that needs to be paid to diet to assure there's adequate protein. Supplementing protein is necessary if the diet's inadequate. And exercise is the tried and true way to improve muscle mass and function. The pharmacologic approaches are on the horizon, and we expect them to be moving forward in more and more clinical trials to establish efficacy and safety. So let me stop there and turn over to the next speaker, who will review in a little more detail some of the nutritional approaches.
Great. Thank you very much, Doug. And our last speaker is Dr. Suzette Pereira. Dr. Pereira is an Associate Vollweiler Research Fellow at Abbott Nutrition, leading the muscle research program that focuses on nutritional interventions to address muscle wasting. Over the past decade, her research is focused on understanding the mechanisms leading to muscle loss due to sarcopenia, hospitalization, and chronic diseases such as cancer. Dr. Pereira leads both the clinical and preclinical research at Abbott Nutrition with the aim of developing therapeutic nutritional interventions for patients across the continuum of care. She actively publishes in peer-reviewed journals and is the co-inventor of over 80 patents. Dr. Pereira is going to share her thoughts on the management of sarcopenia.
Thank you, Cynthia. Can you hear me?
Yes, we can, Suzette, and you should be able to advance your slide.
Okay, fantastic. So good morning, everyone. It's my pleasure to be here and to talk about an area that I'm really passionate about, and that involves management of sarcopenia, especially focusing on early intervention strategies. So Dr. Keel already talked a little bit about some of the strategies that are being considered, and I'm going to take you into these strategies a little bit more in detail. So I'm starting with a slide. Everyone is aware that the consequences of sarcopenia are devastating and can be life-changing. And across the continuum of sarcopenia, depending upon how much muscle loss you have, you can have worse outcomes if it's not treated and managed early. So you have listed some of the common consequences like falls and fractures. There's more evidence showing that there are also poor hospital-related outcomes related to loss of lean mass, eventually leading to mobility disability, loss of independence, and like Dr. Studinsky published, mortality. Now, we should be really concerned because the population is aging fast. This graph is taken from the CDC that projects that the aging population over 65 years will almost double by the year 2050. Looking through the literature, the estimated prevalence of sarcopenia is between 19 and 45% in this age group. It tends to be higher in the older age group. And this variation is based upon what definition of sarcopenia was used. There aren't that many studies looking at the health economics associated with sarcopenia. The most commonly cited study was published in 2000 that showed that sarcopenia-associated health cost was around $18.5 million yearly in the US. There is one recent study just come out of Europe that has shown that there is a 34% increase in hospitalization cost when a patient is sarcopenic versus a non-sarcopenic patient. So this condition needs to be managed as early as possible. Dr. Thiel already went through the complexity of the causes of sarcopenia. You can see it's multifactorial, and many times they overlap each other. So how do we develop interventions that are going to target muscle and strength loss? In certain cases, like a chronic disease, cancer, cachexia, inflammation is a big driver, and there are therapies to address inflammation. But with age-related sarcopenia, it's not as obvious. So to address management of sarcopenia, perhaps it's best to look at factors that are common to this age group. Decreased physical activity is, of course, the most common, and it's well associated with loss of muscle mass and function. But one must also think about a loss of appetite and a feeling of satiety that's common among the older adult group. In addition, we should think about vitamin D status. Vitamin D is well associated with falls and fractures, and it's essential for skeletal muscular health. So over and above, people have a loss of appetite. It has been published that hospitalized patients do not consume a full meal that's provided in the hospital. So what happens is these people go into the hospital and develop malnutrition. Protein is really important to consider because protein signals anabolism in the muscle, as well as provides the building blocks, amino acids for muscle. It's well established now in the literature that the current recommended daily allowance for protein, which is currently 0.8 grams per kg body weight per day, is insufficient for older adults to maintain nitrogen balance. To compound that, results from the Health ABC study showed that 40% of people in this age group consume even less than the recommended RDA, leading to a lot of protein insufficiencies in this population. And lastly, there are metabolic changes due to aging that affect the muscle directly. There's this condition called anabolic resistance, where people have shown that the aged muscle just does not respond as well to a meal as a young muscle. And the exact mechanism is still being worked out. In addition, there might be inflammation within the muscle itself, driving an increase in muscle protein breakdown, and so that shifts the net balance towards muscle loss. So in view of all these, the most promising sarcopenia intervention strategies have been lifestyle modifications like exercise and proper nutrition. As Dr. Keel said, exercise is well associated with improved functional outcomes. The most recent life study that's published has shown that a structured exercise program that included not only resistance exercise, but also aerobic exercise and some stretching and flexibility, helped reduce mobility disability in the older population. With regard to nutrition, I already talked about the importance of proteins. And so there are expert nutrition groups from around the world that have got together and recommended that older adults need to increase their protein intake to around 1 to 1.5 grams per kg body weight per day. And they propose even a greater intake if they have severe disease. In terms of vitamin D, the Institute of Medicine and other societies have agreed that older adults need a higher vitamin D intake. The recommendation is 800 international units to 1,000 international units daily. And lastly, within nutrition itself, there's this evolving field on therapeutic nutrition, and that's the area I actively work in, where we're not just trying to address protein deficiencies, but deliver therapeutic doses of nutritionals like fish oil, HMB, branched-chain amino acids, which will address the metabolic dysfunction going on and restore the net balance of protein in the muscle. I will not talk about drugs because Dr. Keel already went over the drugs, but many of them are looking more specifically at a severe sarcopenic population. I put the slide here to show you that there is also investigation into multimodal therapy. In this case, the study, multi-center study around the world going on in cancer cachexia, where they have combined nutrition, exercise, as well as drugs to see if they can improve outcomes over single therapy alone. And we are awaiting the results of this trial. So what I've gone through today are some of the promising strategies of sarcopenia intervention. But as Dr. Keel said, these are small studies that have been published. And what's lacking are the large validation studies for these various interventions. It would be really important as we move forward to determine guidelines for intervention to standardize on the exercise, the type of exercise, the frequency, the length of exercise needed to mitigate sarcopenia. Standardize on the nutrition regimen, especially considering the disease severity. And identify the population that's most likely to benefit from the different interventions. But I believe having the ICD-10 code for sarcopenia in place will really drive towards optimizing these intervention strategies. And we are seeing that currently with the discussion around the clinical outcomes. We've seen groups like the Foundation of FNIH, Sarcopenia Consortium, working on what is the most clinically meaningful change in cut points. You heard a webinar the last time. The Aging in Motion group is coordinating efforts with the FDA and other organizations to identify patient-reported outcomes that should be included in clinical trials going forward. So this is an exciting time for all of us. And I'm going to end with the last slide to say that having this ICD-10 code in place is really a big step, not only towards driving sarcopenia awareness, but it's really going to drive adoption into clinical practice, establishment of guidelines for assessment, diagnosis, and management of sarcopenia, getting diagnostic tools reimbursed, which would be a big step in diagnosing, and lastly, driving research. I already talked about more targeted sarcopenic intervention studies, but also driving studies to understand prevalence and the health economics of sarcopenia. So I'd like to thank you for your attention.
Thank you so much, Suzette, for your really informative presentation. And we're actually running 5 minutes over time, and we've only lost 5 of our participants. So that just shows you that everyone is taking a lot from all of your really informative presentations. Because we're running a bit over time, I'm just going to close by thanking you all for participating in the webinar today. I'd also like to share with you that the FDA has set a date for their patient-focused drug development meeting on sarcopenia. It's going to take place on April 6th of 2017 at the FDA's White Oak campus. They're currently seeking patients, caregivers, and sarcopenia advocates to participate in the meeting. And you can register via the link on this slide, as well as through FDA's patient-focused drug development page that they have on the FDA website. And I'm going to be sharing the flyer with all of you with a thank you for this. Thank you for joining the webinar. And we're actually going to be having an AIM webinar in February that's going to provide an in-depth look on the patient-focused drug development initiative. So please keep an eye out for an invitation to that webinar, and we hope that you will join and also encourage others to attend as well. And just so you know, the recording from today's webinar is going to be available for on-demand viewing on our website. And thank you all again for joining, and I hope you have a great day.